Hi, this is Elliot Fishman, and welcome to part 2 of our series of talks on transitional cell carcinoma of the kidneys, pearls, and pitfalls. And let's not waste any time, and let's just get started. So let's get started where we left off last time. And I was talking about the various appearances of TCC in the kidney, and I want to show you some examples. I also want to make the point about how easy it is to miss something. If you look at this patient with hematuria, look at the right renal pelvis, it's easy to say, I don't see anything. But if you look carefully, the pelvis looks a bit full, and maybe there's a little bit of soft tissue right there. Maybe I'm just making it up. But you better get some contrast scans. And sure enough, when you get contrast scans and the pelvis is filled in, there's a mass. That's a TCC. Here it is nicely shown on the coronal view. And here it is nicely on the coronal and on the 3D. On the 3D, you also see the irregularity of the lower portion of the pelvis. And that's a very classic thing with TCC. It erodes into the pelvis. It amputates calyces and erodes into the pelvis. Well, here it looks like, not that aggressive a soft tissue mass. You look hard, there is some irregularity, but you look here and it's particularly abnormal. Here's a few more 3D images again showing you that the pelvis and the calyces. Another patient, left side, big cyst. Maybe you pay attention to the cyst. Are you paying attention to the pelvis? Maybe I'm just making something up here. I don't know. But there it is. It's enhancing all the way to 64 when you look at the early phase imaging. What is it? Could it be a high-density cyst? Well, there it is on the coronal view. It's some soft tissue filling defect by the upper pole calyceal region. Very subtle. It's easy to miss. Here it is on the volume rendered view. There is something filling in the kidney superiorly. Compare this to the lower pole right there. Something to worry about. And sure enough, when you look at excretory phase imaging, the calyces are irregular, the pelvis is irregular, and particularly nicely shown on the coronal view. You see how you amputate the upper pole calyces and portions of the pelvis? That's the patient's transitional cell carcinoma. You can see it's very subtle, and that's one of the challenges with TCC. The ones that are potentially curable are subtle. When you have a big mass infiltrating the kidney or going into the peri or pararenal space or having multiple mets in the ureter and bladder, those aren't curable. These are, but it's so easy to miss. Now, I made the point before about coronals and MIPS. Here's a good example. Look at the upper pole. You see how distorted it is? Sometimes you don't see all the calyces always on a MIP. But here you look and you say, oh my goodness, the pelvis is distorted. Something's going on here. And then I look up and the calyces are distorted. The whole upper pole is distorted. What is going on there? I don't know what's going on. But that's a transitional cell carcinoma. Here it is on two more volume rendered image on the left and a MIP image on the right. Another patient, hematuria. Something in the right renal pelvis, soft tissue density. You look at it a little bit later, there's a soft tissue density, and you also notice that the calyx may be distorted. You also note the patient has had a left nephrectomy already for a TCC. When you have a TCC, you always worry about local recurrence, but you also worry about distant disease in the bladder or in the contralateral kidney. Remember, 40% of patients will develop contralateral disease or disease in the bladder. They're going to develop other areas with disease. So it becomes very important to look very carefully, and that's what we see here. We see the mass. Let's keep going. There it is, a few other images, the soft tissue in the renal pelvis. And look at it when you give contrast, you have the excretory phase. Look at the distortion of the patient's calyces. They're destroyed. Classic appearance, transitional cell carcinoma. And here's a few more images of that. The right ureter is okay, but look at the calyces. So it's not just the lower pole. It's infiltrating into the mid pole and into the upper pole as well. And just to show you a few more images, remember my point. Always get sliding MIPS. If you're not a 3D person, I don't care. Have your techs make a stack of MIP images look at the coronal MIPS on the excretory phase imaging. Now, sometimes tumors, larger TCCs, look like renal cells. Here's a patient with hematuria, and on the non-contrast, you see a large mass in the upper pole of the right kidney. You know there's a tumor there. And sure enough, you see the patchy enhancement on the early phase imaging, the normal left kidney. But would you recognize also, besides the adenopathy being present, what's going on by the pelvis? But my first look is, I'm thinking there's a renal cell. I'm not thinking transitional cell. There's some vascularity in the mass, and TCCs are typically considered hypovascular, but they can have increased vascularity, as you see here. And then we'll keep going. The patient has multiple nodes and infiltration into the mesentery and omentum, as well as the right para-aortic adenopathy, which probably makes me again think more commonly of a renal cell. But again, look at the pelvis here. Look at the enhancement of the wall of the renal pelvis. Look at the infiltration in the kidney. It does make the point that transitional cells can have adenopathy, can go to the omentum, can go to the para-aortic region, as you see here. And now you look at the upper pole, it still makes me think of a hypovascular infiltrating renal cell. Maybe you can throw in lymphoma. But the way the pelvis looks, whatever's happening is going to and into or coming from the pelvis, and probably in reality it came out of the pelvis. That's classic for transitional cell. Here's a few more images of that. Here it is with the 3D volume rendering. And just to show you just a few more images, one of the nice things about volume rendering on infiltrating processes, it really gives you a good feel of the true extent of pathology. Here's the coronals. Look at the normal left kidney and compare. Again, a few more images. And then here's the excretory phase. Often these large infiltrating transitional cell carcinomas, you don't see any contrast excretion by the kidney. The left kidney, which is normal, looks good, but you don't see the excretion on the right side. Maybe a little bit in the lower pole calyx. Transitional cell carcinomas are infiltrating. They fill in the pelvis, they fill in the calyces, and so what you have is a hypovascular mass, but the epicenter is in the pelvis, and the epicenter extends into the calyces. So a beautiful example of a large infiltrating transitional cell carcinoma. Here it is with cinematic rendering, very nicely showing you the infiltration. But you could see why I thought about an adenocarcinoma or just a typical renal cell carcinoma. Why I would think also about lymphoma, though lymphoma, when it infiltrates, usually infiltrates the entire kidney, but the pelvis part is not your basic lymphoma type appearance. But again, a large infiltrating tumor was a TCC. Again, just a range of cinematic rendered images to show you this very nicely. Another example, hematuria. Look at the left kidney. There's some fullness by the renal pelvis. Compare it to the right kidney. See, in the right kidney, you have a lot of fat in the pelvis. On the left, you lose the fat. A very good sign of something going on that's bad is loss of fat. It means something's infiltrating into the soft tissue in or around the renal pelvis. Here you can see in the coronal view, something is going on in the upper pole of the left kidney. Here's the infiltration on the early arterial phase imaging. But again, very much like the last case, look at the pelvis. Look how the wall of the pelvis is enhancing. That's a sign of transitional cell carcinoma. You see the infiltration coming down. You see the infiltration going down the pelvis. Here it is on 3D. There's another 3D image right here, very nicely showing you the infiltration of the kidney, the delayed function of the kidney. Again, delayed function can be due to stones, pyelonephritis, renal cell carcinoma, lymphoma, many possible things. But here it's infiltration. It's the pelvis that's infiltrated. Good example here as we get to late venous phase imaging, delayed function of the left kidney, the central infiltration, nicely shown on the coronal. This case also has enlarged nodes in the left para-aortic region, nicely shown. And here it is again, just a few more images showing you delayed calyceal filling, showing you the delayed nephrogram, showing you the infiltration of the pelvis, And on excretory phase imaging, again, that infiltration of the pelvis is there, maybe involvement of the renal vein, definite periaortic adenopathy, and you just don't see the function as you see on the right. So one of the things transitional cell carcinoma classically does, when it's larger and more central, it's delayed function of the kidney, where you see no contrast in the calyces, particularly when there's infiltration. Again, we talk about the different forms, mass-like. We talk about a small tumor in the pelvis, small tumor taking out some infundibulum or calyx, and this large infiltration. And again, here it is when we go to cinematic. And there's just a few nice cinematic rendered images showing the infiltration into the patient's left kidney. And again, the delayed function of the patient's left kidney. All very, very nicely shown in this example. And again, very nice correlation with the regular 3D or the coronal views. And cinematic rendering is very valuable when you're looking at the renal pelvis. That indeed could be very, very helpful. So it's something you need to think about, and it's something that's really good to do. So I think you will find that to be very, very helpful. And here's just one more set of images. Now, one of the things we think about with renal vein involvement, we always think about classic renal cell carcinoma. We always look at the renal vein and then the IVC. Here's an infiltrating tumor in the left kidney, not very subtle, but there's renal vein involvement. Typically, I would say renal cell carcinoma because there's renal vein involvement. But reality is TCCs can grow and invade into the patient's renal vein. In this case, the left renal vein is infiltrated. You can see as you look at the coronal views the infiltration of the upper pole of the kidney. Again, you can think of a renal cell, but this is really an infiltrating process. You're losing the corticomedullary interface. You're losing the renal pelvis. There's something filling in the renal pelvis up high here. And as you can see, it grows down and grows into the renal vein. So I show this case to make the point that TCCs can involve the patient's renal vein. It's not just renal cell carcinoma. Occasionally lymphoma can do it, but TCC can do it. And again, in this case, when you go to the MIP imaging, look at the amputation of the calyces in the pelvis, and particularly to the upper pole of the right kidney, where the calyces are basically just not visualized. Another example. You're looking at these cases and you say, what's going on in the right kidney? It's enhancing, but the corticomedullary interface is not as bright as it should be, and there's something infiltrating, and there it is on the coronal view. But again, this is one I would say right off the top, I could say, well, maybe it's just a renal cell. It's slightly vascular, maybe it's a clear cell. I can't say it's not a papillary, but my first thought is not with the TCC. You get some later venous images, and you see the infiltrating process. Again, lymphoma can give you discrete masses, but not such an infiltrating thing unless it involves the entire kidney. And lymphoma does not tend to involve the calyces. And you see on the excretory phase imaging, look how this mass destroys the renal pelvis and amputates the upper pole calyces. Just a beautiful example of direct extension from an aggressive TCC. So this one is going to have a problem because these are the ones that typically will have additional mets on the patient's ureter or in the bladder, or will recur once they're treated. But again, beautiful visualization of what was, in theory, a subtle mass, mid-portion left kidney, extending to the upper pole. But look at the infiltration on these images. Very nicely shown with 3D imaging as well. Okay, there it is again. Just really nice infiltration. So again, another type of infiltration by transitional cell carcinoma. What about this case? Lots of ascites, adenopathy, infiltrating mass, upper pole right kidney. Again, I'm thinking about renal cell. But the tumor's growing down toward the pelvis. You get a bit later phase imaging. It's really an infiltrating tumor. But again, renal cell carcinoma can be infiltrating. Lymphoma can be infiltrating. And look at delayed phase imaging. The left kidney enhances normally. The right is essentially not excreting contrast. Maybe there's a little bit of excretion going on in the lower pole calyces on the right. Here it is on the cinematic, that infiltration nicely shown. Here again, Classic example. Another example, look at the left kidney. And you can see what I'm trying to do is show you the pitfalls about how subtle lesions could be on non-contrast, how infiltrating they could be. If you only have one phase, you have to notice the differential enhancement, the renal mass size, and the fact that it's infiltrating the kidney, not really a discrete mass. You're losing the cortical medullary interface, but you're losing it where it seems to extend from the renal pelvis up and grow into that. That's what it's kind of looking like to me. Here it is again with the renal artery and the vein extending near the tumor. And again, on venous phase, the mass in the upper pole. Again, very, very important. Now, one of the things we know is that the larger TCCs can very much be more difficult. It could be a renal cell, lymphoma, metastasis, or even infection like XGP. And I've showed you some of those where I thought it was a renal cell or maybe lymphoma. And I guess you can't forget Mets. XGP, we always think about stone and then a non-functioning kidney. But I will say maybe with XGP, I'll put down infection. Pyelonephritis, decreased enhancement. Could you always tell acute pyelo from a patient with an infiltrating TCC? So let's do this. Let's stop at this moment and then come back and let's go back to this slide. We'll start with this slide and talk about some of the challenges of large TCCs. And with that, I'll see you in a few minutes. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.